Sugar Check, an antibody screening for early recognition and diagnosis of type 1 diabetes, a DNP-led community education and screening program by Michelle Fuller. There are 6 objectives that the listener will be able to address after this presentation. Number 1 is to describe the importance of screening for early diagnosis of type 1 diabetes. 2, identify disparities to early screening and acknowledge vulnerability of screening population. 3, discuss the levels of prevention, primary, secondary, and tertiary. 4, discuss nursing competencies, instrumental for the DNP-led initiative to be successful. 5, discuss steps of the Sugar Check program, including community resources. And 6, define criteria to measure success rates. Diabetes is sometimes a confusing disease because the name is used to describe a range of disease, each with a different mechanism of action. The 3 main types of diabetes. Type 1 is an insulin destruction, an immune response that results in the destruction of the beta cells in the pancreas, causing them to no longer be able to create insulin. Type 2 is an insulin resistance, which can be due to genetic factors and or obesity. 90% of all diabetes diagnoses are type 2 diabetes. Gestational diabetes is diabetes which presents in pregnancy. Once the pregnancy is over, it usually resolves. However, this population is at a higher risk factor for developing type 2 diabetes in their lifetime. There is no cure for type 1 diabetes, and the only treatment is exogenous insulin. It is a lifelong disease. It results in hyperglycemia, which is due to the inability of cells to uptake glucose. Again, this is created by the destruction of beta cells in the pancreas. The body then burns fats for fuel, which creates ketones, which lead to diabetic ketoacidosis. Type 1 diabetes, autoimmune reaction, believed to be triggered by both genetics and environmental factors. And it's not preventable. There is no known cause, and people do not do anything to acquire type 1 diabetes. The only known risk factors for this chronic disease are family and age. First-degree relatives with this disease appear to increase a person's risk, but 90% of all new diagnoses have no family connection. Children are also more likely to be diagnosed. However, type 1 diabetes can strike at any age. The disease comes with a risk if not well controlled, which is a lifetime full-time job. Even with strict control, the possibility of these risks still exists. Risks include diabetic retinopathy, kidney disease, neuropathy, and cardiovascular disease. While this presentation focuses on DKA, the end result of high blood sugars over time, as that is usually the presenting manifestation of an undiagnosed individual, the significance of type 1 diabetes also includes risk of coma and even death from hypoglycemia. DKA resulted in 2,400 people losing their lives in 2009 alone, and while it can develop from other processes, it is seen more frequently in persons with type 1 diabetes. Diabetes is a very costly disease. Prevention of DKA could potentially eliminate some of these costs of hospitalization and use of intensive care units by preventing morbidity and mortalities associated with cerebral edema at diagnosis. DKA statistics speak for themselves. It is the leading cause of death in type 1 diabetes. As many as 25% of cases are misdiagnosed. It's associated with worse long-term outcomes, and it should be ruled out with presentation of nonspecific viral symptoms such as nausea, vomiting, or fatigue. The majority of the type 1 population is diagnosed as children under 20 years of age. The younger the child, the more vulnerable they are from lack of communication skills. This is more pronounced in children under 6 years old. Also, parents and caregivers sometimes have a knowledge deficit related to symptoms, the availability of care, and the lack of insurance coverage or change in coverage policies resulting in delayed entry to medical facilities are all population vulnerabilities and disparities for this group. There seems to be an upswing of newly diagnosed diabetes cases. Many studies are underway to reveal a common element. The SEARCH study was funded by the CDC and the National Institutes of Health, and over a decade, spanning 2002 to 2012, saw a rate of increase of 8% annually for type 1 diabetes cases. 17,900 cases of newly diagnosed type 1 were recorded in 2011-2012 in people younger than 20, with the highest rate of diagnosis being seen in the non-Hispanic white population. In this table, for children ages 0 to 19, you can see the white non-Hispanic population have the highest rate of cases per 100,000. The Black non-Hispanic population was then followed by the Hispanic population, and then the Asian Pacific Islander, followed by the American Indian population. The rate increase of diabetes is being seen across ethnic lines. The increase in the Hispanic population brings its own set of disparities. As seen in the previous table, the non-Hispanic white population has the highest rate of type 1 diagnosis. The number of increased cases is being seen in the Hispanic American population. Lack of access to health care affects millions of children, including the Hispanic population. It is generalized across the population from lack of insurance, socioeconomic status, and the possible migrant worker living situations seen in this group. Several levels of prevention exist, as described in Curley and Vitale. Sugar Check is an example of a secondary prevention program in that it is a screening process used to detect type 1 diabetes prior to clinical symptoms. Primary prevention includes activities to prevent disease. Immunization, educational programs, and financial deterrents to participating in risky behaviors are examples of primary prevention. Type 1 diabetes is not preventable at this time. After diagnosis, tertiary prevention would continue with treatment in order to help prevent disability. This antibody screening tests for the 3 known antibodies to type 1, which are GAB, islet antigen, and zinc transporter 8. The Sugar Check screening program was inspired by a study funded by the Juvenile Diabetes Research Foundation and presented in the Pediatric Diabetes Journal. In a community health fair, finger sticks were utilized to check for antibodies to type 1 and not simply blood sugar. This testing would hopefully appeal to more families in the community setting as there is no venous blood draw associated. The simple finger stick could reveal a potentially fatal disease. In previous studies of autoantibody-positive children have demonstrated fewer episodes of DKA, reduced morbidity and mortality. Why community screening? 1 in 300 children will be diagnosed with type 1. Even though screening exists, many physicians do not routinely employ it. Physicians that are not mandated by the state they live in are less likely to screen for this disease at birth. The Georgia Department of Health lists 31 disorders for which newborn screening is currently mandatory. These disorders reportedly have a rare incidence. They're capable of causing significant mortality or morbidity. They strike 1 in 3,000 to 1 in 300,000 children. Type 1 diabetes is not included in this list. There are studies that exist that will check for these antibodies outside of the state-mandated newborn screenings. One of the largest of these, TEDdy study, parents can ask for their child to be included. According to the American Academy of Pediatrics, the overall global needs of children are best met through a team-based care approach that includes children, families, medical, educational, and social caretakers. It encourages these groups to invest in securing the best care possible for all children. While every person diagnosed with type 1 diabetes will benefit from community support, these resources utilized from the beginning can only increase treatment success. Medical testing is cost prohibitive, and many medical professionals are needed to complete the process. The feasibility of the Sugar Check program will utilize an existing health fair in order to share in community testing resources. The DMP will work with all entities to include medical, social, and educational, as well as private donors to obtain funding for this program. Funding will include educational brochures in both English and Spanish, testing supplies, lab costs, and follow-up education. Community partners for this program will be Pine Log Elementary School located in Rydell, Georgia, the Northwest Georgia Public Health, Bartow County Health Department in Cartersville, the DMP, ASN, BSN nurses, physicians, teachers, parent volunteers, and community donors. Every October, a health screening to include hearing, vision, and flu shots is held at Pine Log. Incorporating the Sugar Check program would be economically manageable and would allow access to a larger population. Secondary prevention plan of action for Sugar Check includes the first step, which would be consent forms to be sent home with each child. This would also be included with an educational brochure on the signs of type 1 diabetes, the rationale for testing antibodies for the possible prevention of diabetic ketoacidosis, and any follow-up information. Demographic checkboxes will be utilized to collect data on each child tested. Step 2, each child with obtained consent will have a fingerstick test completed during the annual screening. which would check for the autoantibodies of type 1 diabetes as discussed earlier. Step 3. Results will be collected by the DMP, and each positive test will be communicated to the family in person with explanation of need for follow-up testing and resources available. Step 4 would include follow-up at 6 weeks with each family to ensure that resources have been met to allow for confirmatory testing. It would also give the DMP an opportunity to discuss early onset interventions and further resources. The ANA recognizes leadership competencies in 3 areas: leading yourself, leading others, and leading the organization. The DMP will wear many hats in developing this program and ensuring its success. Adaptability to many roles will be needed, which will require initiation on the DMP's part. Effective communication with the team and motivation for the work to be done will result in a successful health fair. Working with the different community leaders, business acumen, and project management competencies of the DMP will lead to an economically successful program. This screening will be deemed successful not on obtaining positive test results, but on community involvement and appropriate follow-up care. Long-range planning by the DMP will be needed to set up follow-up meetings and resources for affected families. So successful measures would include the number of consents received, the number of children tested, and the number of antibody-positive children, if any, that receive follow-up care. In summary, type 1 diabetes is a lifelong disease which is manageable but not preventable nor curable. The complication of diabetic ketoacidosis may be prevented at clinical diagnosis with early screening for antibodies present during preclinical type 1 diabetes. Children are most affected by this complication at diagnosis. By utilizing community resources and health fairs to screen children for these antibodies, fewer children may present with diabetic ketoacidosis, which is the leading cause of death in type 1 diabetic children. The DMP positions within the community can provide the competencies needed to promote, organize, and manage community screening fairs and follow-up care. Following are a list of references included in this program. Thank you for presenting in this presentation of SugarCheck.